All right, so we're ready to go. And I'm gonna stop my video. Okay, so our job for today is to define what is abnormal when it comes to behavioral, social, and psychological world. Okay. And most of the time when we talk about abnormal psychology, we do uh, have a conversation about mental illness and mental disorders and the like, and that tends to be the majority of what we talk about. But I do want to bring to light that the reason why it's called abnormal, as you will see in this conversation, is that it doesn't necessarily abnormal behaviors or psychological states are not limited to a disorder. You can have deviant behavior without having a mental illness. Okay. The other thing that I do want to mention, because I'm already doing it, is when I say mental illness, psychological disorder, or disorder, those are synonymous terms with each other. I'm meaning the same thing when I say illness as I say disorder. Okay. My preference is when we're talking about mental illness is to use the word mental illness instead of psychological disorder. Reason being is illness is synonymous with physical illness, which is the seriousness that a mental illness should be taken. The term disorder just suggests that the person doesn't have their self in place and they just need to realign themselves and they'll be okay. So, but just to I'll use those terms interchangeable as we go through this presentation. But outside of mental illness, there are also all kinds of abnormal behaviors that we will talk about. For example, deviant behavior is not necessarily a mental illness. Criminal behavior is not necessarily dealing anything with mental illness, okay? As we will talk about as we go through these next few slides, okay? But what is meant, how do we determine what is normal and abnormal? What is an appropriate behavior versus an inappropriate behavior? And there tends to be three approaches, well, and a fourth when we look at it statistically. But the three that kind of drive our perceptions of things like mental illness and deviant behavior start with, excuse me, the egocentric approach. Okay. The egocentric approach is something that is very common in individualized and especially Western cultures. And that is anything that is not normal to me is abnormal. Okay. And so again, I could use our current political landscape. Non-Trump supporters think Trump supporters are crazy. They have disorders. They're nuts. They're illogical. And that is based upon the way that a non-Trump supporter sees Donald Trump, and how could you be that crazy to follow him? Now, with that being said, the reverse is the same for example, Harris supporters. Non-Harris supporters think that people who would support Harris and that is again not logical, not thinking, those kinds of things. So that's a good example of the egocentric approach. Okay. Where we get in trouble with the egocentric approach is when it has very negative consequences on certain populations. Okay. Um, and one example of egocentrism gone wrong is attention deficit hyperactivity disorder. Okay. The highest rates of ADHD based on birth are children who are born in the month of August and September. Okay. The majority of ADHD is diagnosed and in the school setting, and it usually starts with the teacher. Okay. The issue is that the youngest children in the classroom were children who were born in August and September due to cutoff dates. Okay. So what that means is that those children are being then compared to the other children in the teacher's room, and probably because of their maturity, not because they have ADHD, their behaviors tend to be inconsistent, erratic, hyperactive, active. And so those students tend to be are the ones that are sent to someone and said, this child has ADHD because of my centric view of what ADHD is. Okay. So that in some cases is something that an egocentric approach can lead an individual to think about instead of thinking about development, maturity of a child and those types of topics when it comes to determining abnormal behavior. Probably another egocentric view is people tend to think that people who are criminally minded, school shooters, all of that, they must be severely mentally ill. And what that is that's an egocentric protective defense mechanism, because what we're doing is we're trying to separate us from them that do these horrific acts. But again, when we talk about mental health, we'll see that most school shooters, a good portion of people who are in the correctional systems, really don't have a diagnosable mental illness. Do they have mental health concerns? Yes. But do they have a diagnosable illness? No, not really. Okay. And so that's another way that the egocentric system works. In a lot of ways, it's a way of protecting ourselves from those who do things that we think are egregious or something that I would not engage in. Okay. So that's one way that abnormal can be defined. The second way is through social norms. Okay. So in this instance, when someone acts out beyond the social expectations of that individual, they tend to be seen as deviant or not normal, and we can see this throughout history. For example, with the witch trials in the 14th, 15th, and 1600s, we can see this with conventions of when how a person should behave in a given situation, and those who don't act in alignment with that are individuals who are seen as outside, fringe, abnormal. So again, within a society, we can think of those in a fringed society. We could think of minority groups, LGBTQ, or some others right now, in those fringe groups, and they're seen as abnormal, not within the social norm of how a person should act. So that's another way that people and societies have dealt with abnormality. Okay. And then on the broader level, nice check mark, Dr. Peterson, is on the cultural view. Okay. And I want to bring up three examples of cultural influence and how then, as cultures change, they tend to shift. And I'm going to specifically focus on Western more United States type Western culture, so to emphasize this point. Okay. Now, I am not making this statement as a criticism to Christianity or people who believe in men and women of faith and those types of things. So please do not take this next statement in that way. But if an individual came and said, you know what, I see angels, angels come and visit me and tell me what I need to tell the people. And you know what, I am the Son of God. I am Jesus. Okay. I will tell you, we have inpatient mental health facilities that are full of Jesuses. Okay. Um, why am I making this statement this way? All right. In our modern times, someone who came and made that claim would be shot up with thorazine and put in an inpatient facility. Okay. But 2000, what is it, about 2,400 years ago, in a different time, in a different place, people who saw images were visited by things that no one else could see and had this sense of grandiosity, not saying that in the negative term, were seen as people who needed to be revered and listened to versus people who needed to be corrected for that abnormality they're experiencing. And this is an adjustment in culture, and we can see this adjustment throughout. So when we see in the Western world the time of Jesus and time of many individuals of faith, we could look at Muhammad and all of those individuals who saw and heard things that other people couldn't hear, and they were the professors of it. They were revered. Then when you get into the age of close to science and 14th, 15th, 16th century, people who saw those things were demonized and is the basis of things like the witch trials and the hunts of those ages. But then you see a reemergence of that. If we look at the time during here in the United States during the Civil War, there was this resurgence in people who could talk to and communicate and see other entities that other people can see. We see that in the White House during the Civil War, President Lincoln monthly had seances to try and speak and would have clairvoyants come who said they could see things that no one could see and whatnot. Okay. And then we get into Freudian age. We get into the chemical revolution of the 1950s. And again, we see another cultural shift going away from people who could see things and feel things that no one else can see to being more towards an abnormality or a mental disorder. Okay. So this is an example of how culture plays a role in how we view people who have abnormal experiences compared to everyone else. Okay. Another good kind of example of culture um, uh, uh, is the example of here in the United States and Europe with the notion of something called hysteria. Okay. In the beginning of the mental health movement, if you read any of, for example, Freud's writings and everything, the main diagnosis for someone who had emotional outbursts, had troubles regulating their behaviors, those kind of things, the diagnosis was known as hysteria. Hista is the Greek derivative for the female reproductive organs. Okay. So, for example, when you have a hysterectomy, it's the removal of the female's reproductive organs. Okay. Hysteria was assumed to become from the female's reproductive organs. In fact, one of the early definitions of hysteria was the wandering womb. Okay. And that it was the womb wandering throughout the female's body and creating havoc. All right. Cultural influence, though, said that because of culture and the way it was conducted in societies, said that this was a disorder of females, hence it was called hysteria. And yes, this is also where we get the terms like hysterical. That comic was really hysterious last night, though. So that's the derivative of where that came from. But anyways, back to this conversation. But here's why, especially these times, and we still are. Western societies were very patriarchal. Okay. And women were viewed as kind of property or the um, um, needed to be cared for by a man. So for a woman to get medical treatment, they had to obtain permission from their husband or their father. And that's the only way a female during this period of time, and we're talking this went clear up through the 1950s here in the United States. The only way a female could get medical care is if she was a ward of the state, if she had her father's permission or her husband's permission. Okay. And so again, in this cultural thing, men don't have mental issues or mental deficiencies and whatnot. And so they didn't go and seek treatment for themselves. But when the wife got quote unquote a little bit crazy, then I'm going to send her to the doctor. Okay. And so here we have this condition, this main condition that really started off Western treatment techniques as we know them today. And it was totally focused on a female and hysterical outbreak. Now, again, though, as culture has changed and mental health issues in men have become more and more accepted, research actually is showing that men and women have hysteria at about the same rate. Indeed, two out of three studies show that men actually have slightly higher diagnosable rates of hysteria versus women. So this is again the influence of culture and its influence on how we define abnormality. And then the last example of how culture can play a role in our assumptions of mental illness is homosexuality. And I'm using that term because it was a clinical term. Okay. Um, There's something called, and we'll look at it probably next Tuesday or so, something called the Diagnostics and Statistical Manual of the American Psychiatric Association. And what this kind of Bible of psychiatrists does is it provides a diagnostic code for someone who comes in with a set group of symptoms. So depression, anxiety, all those kinds of things. In 1997, I believe it was, when we went from DSM-3 to DSM version 4, homosexuality was no longer a psychological disorder or illness. It was taken out completely. Um, uh, and the question is though, why? And if you look at it, it's kind of interesting. Okay, if let's say we um, decided not to um, consider diabetes a physical illness, okay, what would that require of the medical field in order to do that? Well, they would have to prove that despite not being able to produce insulin, it doesn't have an effect on a person's physical health and well-being. Okay. They would have to have evidence of that. All right. But when homosexuality was taken out of the DSM, it wasn't based on research, statistics, anything. It was because in the 1970s, when you start the LGBTQ movement, you have the women's movement, you get into the 1980s, and then into the 1990s, you see a shift in cultural understanding of homosexuality. Am I going to say that it wasn't still considered fringe or abnormal? No. But basically, the way that homosexuality was taken out of the DSM was the psychiatric community voted on it. It was a vote. It wasn't based on data. Um, Now, I think today we do have sufficient data comparing to when we tried to treat it now to say it was erroneous for us to consider it as a disease and a disorder. We have that evidence now, but when it was originally taken out, it was due to the cultural and social shifts, not due to this evidence that it shouldn't be considered. Okay. But again, we have data now that really shows that it should have never been considered a mental illness, but that's a topic for another day. So those are three examples of cultural's influence on our perceptions of mental illness and abnormality. Okay. What I would like to present is kind of what's considered the statistical method of determining what is abnormal. But again, I'm going to outline this doesn't always work out the way we think it should, but this is the way it should, at least from a statistical perspective. If you measure something long enough, whether it's the growth of plants, people's height, psychological states, if you measure it enough times, it's going to form what we call a bell curve, okay? Where everything underneath this curve represents a person in some place in some time, okay? And the majority of people are going to measure close to what the average or the mean is, okay? So these are the average people. But let's say we have a scale that measures from sadness to happiness, okay? If we're using a statistical methodology, clinical psychologists want to study these people who are in this far tail on this negative end, which represents about 5% of the population. Individuals known as positive psychologists, which I hope we can get to by our last Thursday of class, want to measure these people in this 5%. What makes these individuals super happy? What makes them different from these people? And clinical psychologists want to know what makes these people sadder than all of these people. Okay. And so this is considered the clinical approach or the statistical approach, right? But it has its problems too, because the scale from sad to happiness can vary. Some days we can be extremely sad in the clinical end, and some days we can be extremely happy. So how do we determine someone who is just experiencing human emotions as human emotions and those who have a illness or a diagnosable illness? Okay. And so what I want you to consider here is here's a list of abnormal behaviors. This list is here. There's probably 50 to 100 more that could be added to it. But this is This is a list of abnormal behaviors or emotions that we all experience, okay? Or we will experience some period in our life. We'll all experience sadness. I hope we'll all experience elation. If not, hopefully when you get your degree, you'll feel elated. I mentioned in the sensation and perceptions section that we hallucinate every time we open our eyes. But beyond that hallucination, we will all have a visual hallucination at some point in our life. We'll all have a auditory hallucination some point in our life, even if it's just once. And most commonly, we have olfactory hallucinations. Okay. Now, I do want to kind of stop here because I had this happen to a professor once, and I always like to put this warning sign out there. If you smell bacon and there's no bacon anywhere around, I would like to encourage you to go to the ER. Okay. Because one of the signs of an aneurysm and a stroke, one of the symptoms, and it's kind of a strange one of the symptoms of a stroke or an aneurysm in the brain is the hallucination of the smell of bacon. Okay, so please, if just take this as a symptomology thing. If all of a sudden you are smelling bacon and it's not that you're just craving it, and it's nowhere to be found, please consider going to the ER. But beyond that, we all will experience um, irregular sleep. A lot of people, well, I don't live with domestic violence or in a highly violent place, but I'm willing sometime between the age of 2 and 6, you got in some type of physical altercation with another child in some way, because that's a natural behavior for that age group. Okay. We'll all have depressed moods. The difference between clinical depression and depressed moods is 90% of depressed moods will go away within 90 days. Okay. Um, and we call this what's called the 90-90 rule. 90%, 90 days. If it stays beyond that 90 days, then it's really important to consider getting some clinical intervention of some type. I hope we all have spent time at a buffet. We will all have some delusional thinking sometime in our life, paranoia. All of these are normal human abnormal behaviors. So in a way, they're normal. Okay. So again, the question we have to ask is what differentiates this list from a mental illness? Okay. And this is where I do have to put up my warning. Uh, Keep in mind that this is not a class on clinical practice, on clinical diagnosis. This is an academic conversation. And if you are actively seeking treatment or know someone who is seeking treatment and is on medications for the treatment of that disorder or illness, um, please don't use this academic discussion to change your treatment modality. Okay. If you feel you hear something in this lecture that makes you question whether you have an illness or not, please consult your care provider. Okay. And make sure you speak with a clinician about these issues. Um, so, and I give this trigger warning this morning if I was speaking about physical illnesses as well. I want you all to know this. This would be a sign if I were teaching a class on physical illnesses and diseases. This would be the same thing. So, just want to make sure that that's there. But so how do we define mental disorders? This right here comes directly out of the DSM, so that you can all read that and see how The American Psychiatric Association specifically defines it. I'm going to summarize it with these bullet points right here. Okay. So the first thing that marks a mental illness is that it begins with a cluster of abnormal behaviors. Okay. So for example, when we look at the diagnosis of depression, it doesn't just include a depressed mood. It includes changes in eating habits, sleeping habits, motivation, feelings of elation are different. And all of those different other areas beyond just feeling a depressed mood are clustered together and they present themselves together. Okay. The other thing is that they tend to be deviant, meaning that there's no real kind of logical reason that you should be experiencing these depressive symptoms. For example, you can be at the height of your success, a good job, good family, kids are doing awesome, all of those things in your life. But if you're experiencing a depressed mood, sleeping issues, issues with motivation, that's deviant from the state that you probably would be in without those symptoms. Okay. The other issue is that they're distressful, meaning that they bring up anxiety and stress because you don't know how to get rid of them, you don't know how to control them, and the like. And the other thing, and come back a month from now and keep reappearing and disappearing. That there's a consistent pattern that bring these about. And probably the most important is that they are maladaptive, meaning they interrupt your ability to feed yourself, go to work, have appropriate social relationships, um, um, be able to finish your schoolwork and be successful in your classes. Okay. So those are all, these are what are considered when we're thinking about taking clusters of what are normal, abnormal behaviors and defining them as a mental illness. Okay. And you'll notice again, and these are always the parallels I want to draw, all of these are consistent with what you consider a physical disorder to be. Okay, is there's behaviors that it deviant, distressful, it persists, it's not going away, and it's really interrupting your life. And that's when we go in and we say, I think I have diabetes, or I think I have a heart issue, I think I might have cancer. When we recognize all of these areas, and the same with when we're dealing with mental illness. Okay. So I do want to return to the topic of mental health versus mental illness. And I'm going to use it in the relationship to physical health. Okay. Just like physical health, a person with poor mental health, um, a person can have poor physical health. Let me rephrase this, poor physical health, but not have any physical disorders or diseases. In the same area, a person can have very poor mental health, but no mental illness. Okay. Now, does having poor physical health increase the probability of getting a physical health disease? Absolutely. Does having poor mental health increase the probability of a mental illness? Yes, it does. Okay. But in that same way, we know people who have amazing physical health. There's the health guru who in the 2000, somewhere between 2010 and 2018, He's a health guru. He did the Biggest Loser things in the early 2000s, where they take individuals who were overweight and they would see who would lose the most weight by the end of the program. And he was a very, very healthy person, but he had a heart attack. Okay. And my point of this being is our best bet of not getting a disorder or a physical disorder is through physical and mental health, but it's not always a for sure thing. And I want to just kind of bring that to light. Okay. So let's talk really quick about the dimensions of physical and mental health and their similarities and their differences. So when we look at physical health and mental health, we look at three domains: the biological state of maintaining health, the psychological state of maintaining health, and the social state of maintaining health. Okay. So on the biological end, of course, we know they've been drilled into us. We need to eat a healthy diet. We need to have physical activity and exercise. And we should abstain or moderate toxins such as alcohol and drugs. Okay. And we know that can lead to a more physically healthy life. And even when we get a physical illness, it helps us recover or deal with that illness. Okay. With mental health, we see the same thing. We have to have, of course, a healthy diet. We need to abstain from toxins. And we do need to physically exercise. But we also have to add a level of exercise on that is we have to exercise our brain and our mental capacities. So yes, this is doing crossword word puzzles. It's doing trying to figure out problems, mysteries, those types of things. We have to purposely engage in that kind of mental exercise when it comes to mental health. Okay. When we look at psychological health in physical health, in order to be physically healthy, we have to have something we call a growth mindset. The growth mindset is the belief that I'm changeable, that I can do better, that I can always progress. Okay, if you think of this in the guise of exercise, people who exercise hit this plateau. Okay, individuals who don't have a growth mindset tend to stay at that plateau or give up exercise. Those who have a growth mindset tend to find ways to overcome that plateau in exercise. Okay. We have to have a healthy self-esteem. We have to feel good about ourselves. Okay. One of the advices that is common given is when a person is starting to exercise, they say to act as if you are a healthy person. And that is shown to actually increase the longevity of the person actually engaging in exercise, is if they can see themselves as a healthy human being, as a physically healthy human being. And then self-efficacy, which is the belief that I can do something. This is different than growth mindset. Growth mindset is that I'm improvable, and I'm able to change. Self-efficacy is your belief that you can cook healthy foods. It's your ability to say, I can exercise and I can do those things. It doesn't necessarily mean you'll engage in them, but you believe in your ability to accomplish it. Okay. When we look at mental health, we can see this idea of a growth mindset as well. Okay. And I can actually put this in the guise of things like intelligence. Okay. When it comes to intelligence, there's people who believe that intelligence is genetically set. That once I get to a certain level of IQ, I no longer can become more intellectual. I can increase my intelligence. There's also a group who have a growth mindset that says intelligence is malleable, changeable. I can get quote unquote smarter. I'm not set by my biology. Okay. And again, what do we see? People who have that growth mindset tend to manage mental illness issues better. They tend to be more mentally healthy. They tend to live a more fulfilling life. Okay. Just like physical health, we have to have a healthy self-esteem. We have to think well of ourselves. And we have to have the belief that we can accomplish things, whether they're physical or mental. Okay. We have to do thought engaging activities, this idea of becoming a lifelong learner and engaging in study. Okay. And there is a personality factor coming from trait theory about open-mindedness. We find people with the personality factor of open-mindedness tend to be more mentally healthy. Open-mindedness is the idea that as I receive information, even if it's counter to what I believe, if that information is valid, I can change my mind about it. Okay. I can basically evolve as information comes out. Okay. And then on the social end, again, with physical health, engaging in the social world and not avoiding it, surrounding yourself with those people who want to be healthy, want to be out there, engaging in preventative and regular medical care are all important aspects of physical health. Mental health, we know that sense of identity and belonging are important to mental health. Healthy, intimate, and social relationships, and engaging in preventative social activities and medical care. Okay. I mentioned earlier about school mass shooters um, and how they don't necessarily have diagnosable mental illnesses. But what are some common mental health issues do they have? Well, a lot of our school mass shooters that stayed alive, this is so we have limited, but is that we know that they have no sense of identity. They had no sense. So school shootings, they couldn't identify with the school, with what was going on, and they didn't have a sense of belonging. A lot of times, these were individuals who were bullied, who were rejected by their peers, those types of things. We also know from what information we can glean from is they tended to have low self-esteem and low self-efficacy. And they also tended to measure high on closed-mindedness. Okay. So again, none of these are all practices, right? But none of them had a long-term illness, albeit actually there were a couple of them. I should not, please retract that last statement. The good number of them, the significant amount of school mass shooters don't have an illness, they have mental health issues. They're not mentally healthy. Okay. And so we're dealing with a different barrel when we're dealing with this, and it's important to recognize that. All right. I want to talk for just this introductory part a little bit more about roles of trauma. Okay. If we would have gotten through our child development part, we would have talked about adverse child experiences. Okay. What adverse child experiences are is we have found that children who have more and more negative and adverse child experiences, such as abuse, neglect, um, um, not having access to education, poor physical health foods, those types of things, the more of those adverse experiences, the more mental health issues we see in adulthood. Okay. This is a form of what we call trauma. Okay. And what I want you to think about this is again, just like with physical health, you break your leg, um, you get it healed, there's still going to be scars there from that breakage. You break it again, there's going to be more scars. That's going to make it so gets harder and harder to get that leg back to its complete physical health. Okay. This is the same thing with mental health, especially when we're dealing with compounded traumas, is the effects of continued traumatization make it more and more difficult to maintain a healthy mental health. There are some caveats to this that we'll get to. But let's start, though, this conversation with talking about what is known as post-traumatic response symptoms. Okay. Now, this is the mental health part. Okay. You can have negative symptoms to a traumatic event that impacts you, but it doesn't necessarily mean you'll end up with the illness of post-traumatic stress disorder, which is the illness, which then persists over time across situations, maladaptive. Okay. So, post-traumatic response symptoms occur in reaction to experiencing or witnessing an emotional, psychological, or physical functioning associated with some type of trauma. Okay. This is triggered by events such as an accident, natural disasters, abuse, and combat PTSD. Okay. Indeed, what we know mostly about post-traumatic stress comes from the military in the Civil War period. In World War I, it was called shell shock. And then by World War II and into the Vietnam era, we recognized it as a disorder that needed treatment of some type. So, of course, that's going to be of importance. Um, and then we have acute versus chronic trauma. Okay. And all of these can last a week, months, some can last a lifetime. And I want to make that clear. The reason why I want to differentiate acute trauma from chronic trauma is, can chronic trauma without resiliency factors put in place have significant effects on an individual? Absolutely. But dependent on the severity of the acute trauma, that can also have the same effect as someone who was physically abused their entire childhood. Okay. And probably one clinical example I can provide is I worked with a student. This was years ago. Oh my gosh, this was like 14 years ago. Um, and what had happened is she witnessed a car accident. And after that car accident, she could not even hold her keys in her hand without having post-traumatic symptoms, which we'll get to here in just a minute. Okay. This was an acute event, first car accident, all other measures of trauma. There was no abuse in childhood and no major abuses in adolescence and young adulthood. I think she had a couple bad dates and boyfriends, but that was about the extent of it. Okay. But what happened during this acute event is that the people who were actually involved in the accident one ended up being decapitated and his head landed right in front of her car. Okay. Because of that severity of that trauma, she had these post-traumatic stress symptoms. Okay. And I think it took us like 6 months of pretty intensive treatment to get her back in her car so she could drive to school and back. And that's how long it took for this to recover from. Okay. Um, so this is what we're working with, and so I want to go through the symptomology really quick. There's what's called emotional symptoms, psychological symptoms, and behavioral symptoms of trauma. Okay. The emotional symptoms tend to deal with anxiety, depression, fear and helplessness, and guilt and shame. Okay. Where most of the emotional symptoms come from is this emotional concern that the event can occur again. But it also deals with the fact that something called survival guilt. that brings up this helplessness and this guilt and shame of why am I here? But for example, in the combat example, my buddies died. Okay. And this is a major driver of especially when trauma occurs where people have had a loss of life. Why did I survive and why didn't they? Okay. And there's two examples of this that are kind of clear. The first one is 9/11. Okay. After 9/11, psychologists thought that it should be, if you think of the logic of trauma, it should be the people who are at ground zero that should measure the highest in post-traumatic stress. Okay. But indeed, it actually was people within a 100-mile radius who measured highest in post-traumatic stress. And it was mainly due to these emotional symptoms. They, they were too far away to go engage in helping behavior, but they're close enough to realize that that trauma could have happened to them. So there's this feeling of helplessness. I can't help. Fear. Oh my God, that could have happened. And guilt and shame, that survivor guilt. Okay. Another example of the survivor guilt and this helplessness, guilt, and shame come from modern military folk returning from modern active war zones. Okay. We're actually seeing a higher rate of PTSD in individuals who are indirectly involved with the battlefield. Okay. The highest rates of individuals returning with PTSD are actually drone pilots. And the kind of what we're finding out is you have this drone pilot who is flying it, they have control of the weapon, but they are indirectly involved in the trauma that is about to ensue. And we find that these drone pilots are actually coming back with slightly higher rates of PTSD. Okay. So those are the emotional components. The psychological components, probably the most common that everyone hears about is intrusive thoughts, flashbacks, and nightmares. These are usually experienced due to some type of trigger that reminds a person of the trauma. Interestingly, on these intrusive thoughts and flashbacks, olfactory smell triggers tend to be the one that is most prevalent when experiencing flashbacks and intrusive thoughts. But also, if people speak similarly to the individuals in the trauma, act similarly, have the same mannerisms, can create these intrusive thoughts and flashbacks. The issue that is concerning both on the psychological level and on the physical level is individuals with PTSD tend to be very hypervigilant. Hypervigilance in that they're always questioning, they're always scanning the room. It's the veteran who sits themselves in the restaurant so that they can constantly be scanning everyone in the restaurant, and they sit against a wall to make sure that they don't need to be vigilant behind them. And this then creates the difficulty in concentrating if you're constantly hyper vigilant about what's around you. Okay. On the physical end, the hypervigilant is being in a constant state of fight and flight in heightened physiological condition, which often breaks down the individual physically. And so it's not uncommon for again, I'll use veterans as an example, for a military personnel to come back, develop PTSD symptoms with hypervigilance, and they end up becoming very physically unhealthy. They start losing muscular density, bone density, and it's because their body is in this constant arousal state that causes that. Okay. And then behavioral symptoms go again is avoidance and reminders of these triggers, which cause these uh, irritability and aggression, substance abuse, and social withdrawal. So these are all very common symptoms of what we call post-traumatic response or symptoms. Okay. Now, within our Native American community, I think it's also appropriate at this time to bring up the issue of historical trauma. Okay, this is important because, well, first of all, let me define what historical trauma is. Historical trauma refers to a cumulative emotional, psychological wounds across generations caused by traumatic events experienced by a group. Okay. If you watch that second personality video that I wanted you to, I talked about Carl Jung and what he called the collective unconscious. That collective unconscious is the unconscious experiences of all of our ancestors that then influence our behaviors today. Okay. This is very similar to what we're talking about with historical trauma. It's the accumulative traumas of our past, of our ancestors. Okay. For Native Americans, this includes colonizations, forced removal, cultural suppression, and systematic discrimination. I think genocide should be included on this slide as well. And class, I'll be honest with you, I always get this question. It's usually from someone of privilege, a white European or someone like that, who comes and says, well, everybody in everyone's history has some past trauma. Um, we all have been through wars and battles. Our ancestors have been through wars and battles, and the probability of your ancestors being, sexually assaulted are almost 100%. All of it, everyone has historical trauma. And they say, so what makes this any different than anyone else? And this is the answer, okay? Is when we look at cumulative trauma for the majority of groups, it's happened over thousands of years. And that collective trauma has been dealt with over these thousands and thousands of years by our ancestors. Okay. What makes historical trauma unique to Native Americans is this historical trauma has happened within a very condensed period of human existence. It's happened within about 624 years. And that condensed trauma has much more of an influence on Native American individuals than those who came from other cultures where that trauma has been spread out by centuries and millennia. Okay. And we see the same kind of thing occurring, for example, with African Americans who came from slavery, because that trauma happened within that condensed period of time. They have difficulties with the historical trauma within their population. When we look at, for example, Jewish populations, now they've had trauma that has existed through millennia. We can see this clear back, the pharaohs of the old Bible and all that kind of stuff. But what happened during World War II was a condensed concentration of trauma. And now that we're 3, 4 generations outside of what happened in World War II, we do start to see some youth from Jewish descents from the Holocaust and World War II have this collective historical trauma as well. not to the levels that we see with Native Americans or and with African Americans, but on a smaller level, I would say, put it that way. Okay. So, and I know I mentioned this in this class, there is even a growing body of evidence that we can see these traumas on genetic codes. There's genetic markers that have been identified. Again, like I said earlier in the semester, we kind of have to wait and let science do its job with some replication and everything. But there does seem to be a physical transmission of these collective concentrated traumas. Okay. So what does these traumas often manifest in? I'm going back to my mental health example. Okay. Um, this is one aspect of being a Native American and dependent upon how much your tribe had experienced removal, colonization, and suppression that also increases the chance of challenges with mental illness and mental health issues. We know loss of cultural identity, social economic struggles, disruption in family and community structures. Okay. And so, but as I hope I show that tribes that really focus on the mental health of their community tend to have resiliency for these historical contributions. But in some cases, we have to remember that there's what's called a compounding effect of trauma severity. Okay? Because trauma is a function of our collective or historical traumas, but also our lived traumas, whether we were abused as children, we lived in poverty, or as adults, we struggle with relationships and employment and all of those types of things. If we struggle with anxiety and depression, okay? But there is this other factor called resiliency, which I'll get into when we talk about recovery from mental health or mental illness issues later on. But I just wanted to kind of highlight these issues for right now. Okay. So just to kind of close out this section on historical trauma, these are some of the ways that we're finding can help communities deal with historical trauma, cultural responsive education. This is something your college continually works on. Yes, do we struggle with it? But we want to bring a sense of what's called indigenizing our curriculums and making it more incorporative and more inclusive. Um, we want to implement trauma-informed practices. I'm actually going to Northern Arizona University after this class because I'm giving a talk tomorrow at their Native American Center on doing what's called trauma-informed teaching practices. Community engagement. We find that collaborating Native communities to integrate traditional knowledge, language, and practices into education, much like TOCC tries to do, and promote resiliency, focusing on strength, identity, and empowering students through leadership and advocacy opportunities. So these are all kind of approaches that build resiliency and build one's mental health if you come from these groups with historical trauma. Okay, what we're going to, I'm going to end real quick right here and ask if there's any questions. What we are going to begin again on Tuesday when we return, we're going to
Put your
look
name in
at
the chat. So how much? Oh, you did? Okay.
we're going to look at the original theories of mental illness, which is called moral corruption theory, that people who are mentally ill tend to have some type of dysfunction in their moral judgment, those types of things, and and we'll see that this still has had an influence today because people feel that because they have a mental illness, they must be lesser than everyone else. And this is a result of the centuries of what's called moral corruption theory dealing with mental illness and something that we all need to advocate to quit. So, but I'm going to stop here.